Okay, so buenos días a todos y a todas. English
Good morning
speakers,
to everyone.
the interpretation button at the bottom of your screen to English to hear an interpretation of the Spanish. Okay, bienvenidos al cuarto y último día.
Welcome to the fourth and last day of the virtual meeting, Clinical Research as a tool to tackle cancer better in Latin America. My name is Deisha Kristen, Cancer Research and Biostatistics, founding member of the Initiative for Latin America of SWOG and the Statistics Center of SWOG Studies. Today, in the first session, I will be moderating the panel with Dr. Erika Saavedra from the Oncologic Collaborative Group for Research. I have some notes on the Zoom technology. First, if you are calling from a cell phone without Zoom app, you will just receive the audio, but not the video. In case of any question for the panel members, write that down on question and answer. Please include your country in case it is relevant for the answer, and it helps us guide the answers during the discussion. Please write the question during the presentation. This facilitates our work to see where the interests are. If you have connectivity problems, you can get closer to the server. You can connect your computers directly to the internet, or you can log off and then log back in again. We're using interpretation services. Down below, there is an option for interpretation, and you can choose the corresponding language. A disclaimer: the purpose of the services of interpretation is to promote a better understanding of the conference, but this does not replace the original. No person or entity will be liable for errors, omissions, or ambiguities in the interpretation provided during this conference. Now I'm going to give the floor to Dr. Alejandro Corvalan from the Catholic University of Chile and researcher of the Advanced Center for Chronic Diseases.
Gracias, Dacia.
Thank you, Dacia. I would like to welcome everyone to this fourth and last day of this activity on research in Latin America. And I would like to show you what GOCHI does, what we have done these years to have this partnership with SWOG. GOCHI is a medical research group that was founded in 1998. It started with 7 founders and 15 members, and it has grown till 2020. It's been doing research via European groups and then American groups. We have joined SWOG in the last years, and we have grown. We are doing clinical research, translational research, and this has to do with the changes in clinical research these years. We do research basically in breast cancer, but in gastric cancer, colon cancer. And these are some of the publications GOCHI has taken part worldwide. Some of a very high level. We feel so proud about it. And this one, number 3, is USLACN, the Latin American Network for Breast Cancer Profile. We are a small group, 5 people. There is a board. I am the chair. And it has a big network, more than 200 members scattered around the country. So we can have a very good network for clinical research. And this is the milestone that made us go to translational research, which is LACRIN, that did profiling in breast cancer. These data are about to be published. These are the milestones from 2009 to 2014. As a result of this Latin American collaboration, we had a very strong network with an Argentinian group for GI tract tumors. We hold this course 1 year in Santiago, 1 year in Buenos Aires. And finally, we have accepted SWOG's invitation to be part of this. And this activity that we will close today, clinical research for the tremendous cancer burden we have in Latin America. And so I will invite you to this last session. I would like to thank GOTI directors, Dr. Saavedra, Gamboa, together with Dacia, will moderate today's session. Thank you very much.
Muchas gracias, Dr. Corbalán.
Thank you, Dr. Corbalán. Well, good morning, good afternoon. We will start the first session. I'm going to welcome our first panelist, Dr. Pamela Eguiguren Bravo. Dr. Eguiguren is director of the Public Health School, Dr. Salvador Allende of the School of Medicine of the University of Chile. She's a midwife, master's degree from Universidad de Granada, PhD, Public Health, University of Chile. She's assistant professor of the program Health and Community. Her research line are the study of the functioning of health care networks in the area of gender inequality, sexual health and reproductive health. She is responsible for the project evaluation of effectiveness of different strategies of integration of healthcare networks in different Latin American countries funded by the European Commission. Dr. Eguiguren will present Project Equity, Lessons Learned from a Participatory Action Research Approach. I leave you with Dr. Eguiguren. Go ahead.
Thank you very much. I will share my screen.
Por favor, si me pueden indicar si se está viendo.
Is this showing all right or not?
Okay, muchas gracias. Bueno, buenas tardes. Saludos a todos.
Good afternoon. Greetings to all of you. I am very happy to have the possibility of participating in this important activity to share an experience with you, which probably is different to other research. This is a project, and I would like to let you know what participatory action research approach has been. We have wanted to analyze how comprehensive the network is in the northern part of the metropolitan region.
¿Podemos usar la pantalla completa para ver mejor las diapositivas?
Perdón, creí que estaban viendo la completa. Dame un segundo. Muchas gracias por avisarme.
Sí.
¿Ahora sí?
Sí, ahora sí. Gracias.
Perfecto. Bien, este es un proyecto
This is a multicentric project directed from Catalunya, where a European counterpart participates, which is the Institute of Tropical Medicine in Belgium, and 6 Latin American countries, Mexico, Colombia, Brazil, Argentina, Uruguay, and Chile. And it is a project that has grown from 2013 to 2019, and I would like to let you know some relevant aspects of the design to try to understand the process and the results of it. In the first place, this trial starts focusing the approach of fragmentation of healthcare in health systems, a problem that is shared in the region and also worldwide, I would say. And we know with accumulated evidence the negative effects that fragmentation has when we speak about healthcare, impact upon effectiveness, efficiency, and also it produces inequities, this fragmentation. So the trial, the equity has there's an equity LA1 that raised evidence regarding the importance of articulating healthcare to have equitable access. The purpose was to assess the effectiveness of different strategies of integration of healthcare to improve coordination and quality in healthcare networks in different services of Latin America in the countries that I already mentioned, with a design of a quasi-experimental trial with an intervention that was designed and implemented in the framework of the trial and a measurement before and after to check its effectiveness, with an area of intervention and control, and a research participatory action approach, combining qualitative and quantitative methods. Very briefly, just to stress that the focus of the trial was studying coordination. How can we coordinate and concentrate services, and three types of coordination we're taking into account: information, clinical management, and continuity of relationship, and distinguishing this concept of relationship continuity from the perspective of the users. So the trial studied quantitatively the experience of professionals and teams and also users. A general scheme of the design of the trial to check some relevant aspects. The length starts in 2013 until 2019, and it generates in the area of intervention a structure which is a local leading committee to the left. Here we share work between the leaders and the managers of the network who are in charge of leading the technical aspects and policy aspects. And then the schema of the study, we have the baselines and then the design and implementation of interventions constructed in a participatory way, and the evaluation at the end with an analysis that compares intervention and control. Now going into the details of the process of design and implementation of the interventions, and to know how the research process is integrated into that participatory approach. First, the study area or region, 29 health services in Chile, and through them, Chile organizes its healthcare networks. The area of intervention was the Metropolitan North Health Service, and the control area was the Metropolitan South Healthcare Department. Let us remember that the control area had placed the role in a before and afterwards in the measurement, but in the area of intervention, we have the participation of 3 of the 8 municipalities of the Northern Healthcare Metropolitan Service. In primary care in Chile is managed by municipal governments because this gives it a structural special characteristic, and this is one of the things that creates fragmentation in the system. We work there with the municipal departments, with the directorates of the municipalities of Independencia, Recoleta, and Huechuraba, with their networks of CESFAM and SEGOS, and this is focused in the coordination and continuity of care of chronic adult patients. The reference hospitals of that sub-network is the San Jose Hospital, the Directorate of the Northern Metropolitan Health Service, and us as Public Health School. Here we see some images of the local leading committee, which is this the structure that has been fundamental for the participatory approach. There we have had monthly meetings throughout the trial, and it has continued to work afterwards as well. This Comité Conductor Local or local leading committee, together with the academic team, made the decisions about research, and it begins the participatory process with teams from throughout the network to disseminate the results. That is, once the committee meets, we establish the baselines, and the results were a feedback for all the teams of the three health services of the three municipalities, and we gave a feedback with quantitative and qualitative data. And in this way, we generated a process that took several months of reflection, of characterizing the problems, of generating proposals. And we had a permanent feedback in this. We had a dialogue process, actually, which led to a smaller participatory platform in order to facilitate the work. And there we worked, we systematized, and we had a dialogue between the different levels. Here we have all the levels of the health service, and we prioritized two problems, and that was the fact of not seeing a shared perception of the network, and there was limited communication and trust and collaboration between the professional teams of the different levels within the healthcare service. So this led to two interventions, induction program for network work, and one of the activities were levels at different levels and video conferences between primary care and secondary and tertiary care. That process was a process that had specific characteristics determined by the participatory method. And there were cycles. We designed jointly the intervention. We implemented a first pilot program. Then we performed activities to obtain quantitative and qualitative data. We wanted to listen, and then this led us to a new design and a new round of implementation. This brought us to August, September 2017, when there was an important moment of the Comité Conductor Local that presented this experience to the Ministry of Health. There you can see the pictures. And this was due to the success that the experience had in terms of how we were helping to articulate the network through all this work. Some figures of what we did by end 2017. That's the moment when we measure after the intervention. But this continues until now. What are online advisorship? This was something new in those days, not today, but these were online advisories every 15 days in order to share updates on diagnosis, referral protocols, etc. The interesting thing is that the protocol generated what you see in this picture here, which is not equal to what we had in the beginning, because in the beginning, we started with what is classic, an expert talking to the APS doctors, and this grew in participation, and there was a greater exchange between teams. The relationship, the dialogue changed, and the induction to working in network. Here you can see some pictures. There were visits from hospital to primary care, from primary care to the hospital. We exchanged vital information for the users to easily move between the two levels. For instance, to know which is the pharmacological armamentarium in primary care, not to refer a patient that has to continue his or her treatment there, the way in which you prescribe for a patient to receive, fill his prescription in primary care. Well, there are a series of things that were shared, but especially the knowledge of the realities of the different levels, because given the fragmentation, there was little recognition of what happens between one level or the other. And we have the hierarchical relationships also, and the participatory process created bonds and communication. Here we can see a little bit of the online advisories. In 2018, we had a second way of communicating. Practically after the first pilot program, we incorporated the 8 municipalities of the northern healthcare area, not only the first 3 ones. And there was a second type of advisories, smaller ones with less municipalities to deal with more specific issues, like analyzing the case of concrete patients. Which have been the contributions and the results based on the measurements we've made, both qualitative and quantitative, in terms of online advisories? They allowed a direct and effective communication between teams, also a perception of greater effectiveness to solve critical cases, have an effective and direct communication, an efficient tool to generate agreements, to understand new protocols, to manage different types of pathologies. The way in which I took care of the patients with nephrolithiasis changed as of that day. That was a result of this work. We have the participation of the CESFAM teams of the Northern Network. I would also like to stress the fact, well, today we have special protected time for this work. The method is validated and appreciated. And the interesting thing is that the design of which strategies are going to be implemented come out of a consensus of teamwork. So when it is an idea or a strategy that starts from a group, it starts with everybody willing and engaged to implement those ideas. And also another sentence speaking about the depths of the bonds of the communications established. We have changed. We will never be what we were again. And that explains a little bit why the intervention today, even though the project is over, continues. And in this context of the pandemic, this has been an important mechanism to solve critical cases. As to the measurements, just 2 results. The coordination survey has several questions. One of them is, doctors of secondary and tertiary level do recommendations, diagnosis, treatments, and give other guidelines to the primary care doctors for the follow-up of the patients. When we started in 2015 in the area of intervention, this answer many times had 40.1%. as to whether these indications were given. Afterwards, we reached 53.9%, which if we compare, we can see that the 2 networks started in 2015 with 40.1 and 46 in the control. In 2017, we have 53.9 in the intervention group and 42.1 in the control group, which dropped since there was an increase in the intervention side. Another result is counter reference, started in 61.3 or counter referral, and it went up because the southern network had reached those levels. This participatory process, this research action participatory process had synergies with other processes as well. Given articulation was created, dialogue was established, and I think a big thing is to place the user in the center and then articulate and establish the common goals of the network. Another impact is that this advisory moved towards the National Cancer Institute, and my recognition to all the stakeholders of the network, to Patricia Espejo as a nurse of San Jose Hospital, Dr. Isabela Barca from InCancer, because they worked with the methodology. And so we generated this online advisory now tailored for cancer, and that was targeted to what everyone really needed. For instance, indications for endoscopies could be given from the primary care, which was an important change. Conclusions: there's a contribution which is evident from the online advisories that has helped generate the bond between primary care and hospitals. There's a joint management of a joint care of the patients. Bonds have been created in the network. And in the process of collective construction, there's an appropriation of the intervention. We have joint reflection, horizontal dialogue, mutual respect, and the network becomes more important than just one institution. It's vital to have the participation of decision makers, recognition and respect to the different groups. And before concluding, I would like to mention that based on this experience, this has been included in the network programming and planning guidelines of the Ministry of Health, and there's an article of the results at an international level, and we've just communicated with InCancer, and we want to participate with the same consortium in another project focused in giving a continuity to these advances in cancer, financed by Horizon 2020 recently. Thank you very much. And this last image for us represents this research strategy that generates from bottom up the solutions that we need for the problems that we find in the articulation of the network. Thank you very much, Dr. Pamela Giguren.
It's very nice to see a presentation that includes qualitative research. Next speaker, Dr. Tami, Assistant Professor of the Department of Epidemiology, Human Genetics, and Environmental Sciences of the Center of Health Sciences, University of Texas, Houston. She also works at the School of Dentistry and at the Center of Cancer, MD Anderson. His research is focused on two specific areas: prevention and control of cancer in vulnerable specific populations, including sexual minorities and gender groups and people that live with HIV/AIDS, and the use of telemedicine platforms and to train medical care professionals or healthcare professionals in different areas that are not catered in the United States. Welcome, Dr. Tammy. Thank you very much. Can you hear me? All right. I would like to thank all of you for this very kind invitation, particularly to the organizers of this symposium, and especially Dr. Crowley for his support given to the initiatives we have proposed for the Latin American initiative of SWOG. I will show you what we have done in terms of mobile tools to train oncologists in smoking cessation.
Y quería comentarles un poco cuál es.
And I would like to tell you about the rationale and the reason why including smoking cessation in the oncologic area. Many people know that individuals that have a cancer diagnosis, well, there is a change in their lifestyles. And these are usually opportunities that can be used as a time to learn and change behaviors. For many of the patients who are diagnosed with lung cancer, and in case of other cancers, there is an increase in smoking cessation. This is not only focused on cancer diagnosis. The cancer centers can, and in some countries, they have been more proactive to prevent cancer. They can promote and lead efforts for prevention and cessation of smoking in their countries. And this is what we see here at the beginning of this continuity. There is a very good opportunity to establish interventions and educational programs aiming at prevention and control of smoking. But when the patient has been diagnosed, this is a moment for teaching, a moment when the patient is open to change some behavioral patterns. But then we have to understand that helping this patient to stop smoking can have positive outcomes in the oncologic treatment. And I'm going to speak a bit more about that in the next slide. And finally, we can help the patient stop smoking and keep him like that. This is what will guarantee a better quality of life and a longer survival. I wanted to tell you about this paper because it was in 2011 when I joined the MD Anderson. And I joined a team that was doing smoking cessation in HIV. I was brought to the team as someone that knows the clinical landscape of HIV infection for more than 20 years. That was my main line of research in Venezuela, Latin America, HIV/AIDS and its repercussion on the oral cavity. And this paper from my mentor and one of the leaders, and she keeps being leader in smoking in the United States, Dr. Ellen Greets, she started to explain the importance of smoking cessation in cancer patients in 1991. And 20 years later, I read this article and I realized that some countries, Mexico, Brazil, have made some progress, Argentina too, very important advances in control and prevention of smoking. Also Uruguay and many other countries, including mine. The inclusion of smoking in the comprehensive approach of an oncological patient is not something that has been fully accepted. So it is so relevant to include prevention and cessation of smoking in oncologic centers. So in a patient, we have lower levels of pain if the patient stops smoking. But if he continues smoking, there is low response to chemotherapy and radiation. There is more lung toxicity. There are more chances of recurrence of that cancer. There is suppression of the immune function, and there is a shorter survivorship. But if this person stops smoking, we know that there are no delays in therapy or interruptions of it. There is a faster healing after surgery. There is more effectiveness of chemotherapy and radiation. There is a decreased risk of heart disease and cardiovascular complications. And there is a drop in mortality due to cancer. That's why we can see in this triangle that the smoking cessation has a direct impact on the patient that will go to oncologic surgery, or the patient that goes to radiotherapy, or the patient that is on chemotherapy. I had the chance and the honor to have been chosen amongst the individuals that received the Impact Award given by the Hope Foundation. And that was an opportunity, a great opportunity, since that was the first effort made in research of smoking through SWOG in Latin America. Not the first effort in Latin America, because we know, as I said, many countries have led the prevention programs and smoking cessation, but through SWOG involving cancer centers. This time we worked with Colombia, Peru, and Brazil. And what we proposed was a mixed course that had virtual components and face-to-face components, because we wanted that the collaborators of each institute to feel participating. And regarding the content of the course, 30 oncologists in Colombia, 30 in Peru, and 30 in Brazil. We did a historical and epidemiological review of tobacco consumption and cigarette use in Latin America, a second module on the chronic conditions and cancer associated to smoking. Number 3, prevention and cessation of smoking and interventions for that, including behavioral, that were happening not only in the United States, but in the region. And finally, module 4 that covered topics that included medications and pharmacological therapies that are used in the programs for smoking cessation. After giving that virtual course for 1 month. We continued for 6 months, having once a month contact with those 90 participants through what we called virtual meetings. Those meetings of 1 hour duration gave the chance to speak about barriers and opportunities for smoking cessation that were faced by each one of those individuals in their own countries so as to enhance mutual learning. These are preliminary results. Right now, we are with our collaborators from Peru and Colombia, most of them nurses, the nursing team. They are doing the definitive statistical analysis to have the manuscript as soon as possible of the main findings of the STOP project. I was mentioning individuals with a proportional distribution between those having more than 30 years of age and less than 30 years of age. Gender for both countries, most were women. Education in Colombia, it is balanced. Also in Peru, those that had university studies or undergraduate and postgraduate studies. And according to the Wi-Fi access at work, in Peru, there is a much higher access at the National Institute of Neoplastic Diseases, which was a cancer center we worked with, as compared to the National Cancer Institute in Colombia, which was the center where we worked in that country. Many of you might wonder, where are the outcomes from Brazil? Unfortunately, COVID hit the cohort of 30 in Brazil. This was the last cohort in starting the training program, and many of the activities we planned couldn't be performed fully. I won't go into details, but what you can see is how in the assessment we did before they took the training, this is the group from Colombia and this is the group from Peru, we see how there is a significant increase in blue of certain aspects that have to do with knowledge and attitudes of those individuals to provide smoking cessation services in their oncological office. Now, whether there were barriers and obstacles for those professionals? Yes, of course. And this is something we learned during the virtual meetings. I told you we were holding once a month. There were problems to collect data because in many of our centers, there is nowhere to take notes. There are no ways that are approved to do a program for smoking cessation. Now, you only ask whether the person smokes during the first visit, but not in the other visits. There is also a very short time to interact with the cancer patient because there are other priorities in relation to the chemotherapy, radiotherapy treatment, and the fact that in some of the countries, there are no clear national guidelines for smoking cessation. The patient has an attitude of fatalism, then why am I going to stop smoking if I'm going to die of cancer? And the availability of medication for smoking cessation, that barrier was discussed a lot because there is no availability in the pharmacies of nicotine patches. It seems that drug companies bring not all of the products. Sometimes the cost is high for the patient. And I have to mention that all of those comments we received from the participants were comments that we took into account to think of a second phase. What do we mean by those notes? After we provided the training course, many of the complaints were that they had to go back to the slides to review the information, especially everything regarding the type of medication, the medication to recommend for a patient that wants to stop smoking. For many oncologists, this was the first time that they were doing smoking cessation. They didn't know how to start the conversation. Many of them thought that doing smoking cessation would require a long time and very specific training of long duration. And it was a surprise when we gave them the tools to see that with only 3 minutes talking to the patient, you can do a smoking cessation and motivate the patient to take that step. Part of what we discussed is to create a mobile app. We had tried in the stock study an algorithm to make decisions. So the oncology staff that wasn't training, whether they would indicate nicotine patches, whether they did motivational interviews, what was the behavioral approach and drug approach that should be personalized to the patient according to the face of the patient. Patient is not decided whether to stop smoking. Maybe we need to have a more intense advising. Creating this algorithm is something we did 3 months later once we started the training program. And we're able to see that we facilitated the fact of doing smoking cessation. One of the problems of this algorithm is sometimes in some spaces or areas of the hospital or of the cancerology center, the Wi-Fi reception wasn't so good. That's why we said the solution is to create a mobile app that the individual can have in his pocket and be able to use it with the patient. Using it also as an educational tool so as to maybe show to the individual that is receiving the advice, we can show how the lung of a smoker looks comparing with a healthy person, and how this can have an impact on his quality of life, although you have smoked for many years and you are on cancer treatment. Now we are developing the version in English of the mobile application with internal funds of UT Health. And we're sure that for the first trimester next year, we will be trying with oncologists in Houston. But last month, in collaboration with the National Institute of Neoplastic Diseases in Peru, a financing proposal was made for the Fogarty Center. And this was a very big effort because we wrote it in less than a month. And there we propose not only changing knowledge, but attitude and practice through this mobile tool of oncological professionals that would result in helping the patient stop smoking. What we propose is that smoking, as it happens with many other behavioral interventions, be part and parcel of the care of a patient with cancer, since this translates into the success of the oncological treatment. And this improves the quality of life of the patient, which is what we are seeking with those interventions. I would like to thank the SWOG initiative in Latin America, especially Dr. Mohar, who has been one of the greatest enthusiasts in the work we're doing for prevention. The whole team that has supported us from Hope Foundation, Joe Horn and Morgan Cox. Without the STOP study where we got the pilot data, it would have been impossible to make this new proposal for the National Cancer Center in the United States that we hope will fund us. Then the collaboration and the willingness of personnel of Institute of Neoplastic Diseases. I have to do one thing, the director, whom we were sort of harassing to get a letter to support this application for financing. We presented Dr. Hugo Fuentes. He was crucial from the investigation area to accelerate the steps, and for the collaborator, who is the director of nursing in this institute, Dr. Cosme. Besides the collaboration by Dr. Vidaurre, that was a joint effort, day and night. But we were able to send to the NIH. And finally, CRAB, with Dr. Crowley and Kurt Malloy. They felt very enthusiastic for joining our team and collaborate through biostatistics services and so as to help us do the necessary statistical analysis for this project. I would like to thank also all of you for your attention. And finally, I have to tell you that there is a new study. This is my last slide. It is PRIDE. Well, you know that I do research in Latin America, but half of my research agenda is with the sexual and gender minorities in the United States. Since 2014, we have gathered data on risk factors for cancer in that population. Now we're expanding the survey to Latin America, and we invite each one of the cancer centers that are part of the SWOG initiative. I invite them. Maybe they can contact me. There isn't much what you have to do. It is an online survey, but you could be the bridges to get in touch with an organization that is working with sexual and gender minorities in your countries and to distribute the link of this study. Thank you very much to everyone. It was a privilege to be counting on SWOG and its members and learn from you. Have a very nice afternoon. Thank you, Dr. Tammy. Thanks for your excellent presentation. Congratulations for the initiative. The tools that you have developed for a smoking cessation program have been very interesting. It is a clear example on how to stimulate other researchers to propose the project. I would like to remind everyone, please write down your questions on the Q&A icon to then answer them at the round table. And continuing with our program, I'm going to introduce our next speaker, Dr. Jesus Antonio Acosta. Dr. Acosta is a gynecologist from the National Cancer Institute in Bogota, Colombia. He's an expert in robotic surgery and minimally invasive surgery, governing member, Soul Cancer Research Network of governors and has several publications in ovarian and cervical cancer. Today's presentation by Dr. Acosta is surveillance after treatment of locally advanced cervical cancer. I leave you with Dr. Acosta.
Good afternoon to all. I would like to know if I'm sharing my screen okay? Yes, perfect. Well, it is a pleasure for me and an honor to participate once again in one of these meetings. Despite the difficulties that we are having, I feel very honored for the invitation, and I would like to thank all the organizers. This is a project or a research idea that came up some time ago and that we want to reactivate. And I would like to show you what we did and which are the steps to continue and probably conclude this work thanks to SOC in Latin America. It has to do with surveillance of or follow-up of patients with locally advanced cervical cancer. Even though we could think that the United States cervical cancer is not a public health problem as it can be in our countries, we see that according to recent data from this year, about 113,000 women in the United States have a gynecological cancer diagnosis. And of this group, about 14,000 women might have a diagnosis of cervical cancer, which is a rate of incidence of about 8.5. And of this rate, about 50% or 35% of the women might have a locally advanced cervical cancer. This implies also that about 800,000 women will be survivors of cancer treatments, and there will be an increase by 25% in the next 10 years, basically through the populational effect. As the population grows, the absolute number of individuals with cancer that survive obviously also increases. These are the dates of cervical cancer in the United States. And if you go to the last row, it is interesting to see how there is a difference in this country if we compare the different races and how the Hispanic and Asian groups and probably Afro-descendants have a higher incidence compared with the global incidence of cervical cancer. These are the data of our country. You see that they are very similar between the countries. Some have a little bit more incidence. The mortality is very similar. And this is something that we should also take into account. After the treatment of cervical cancer, about 1/4 of the patients will recur. And there is a big heterogeneity. There's a big range of ways in which recurrences appear. There can be multiple recurrences in an important group of these patients, and most of them recur during the first years, 2-3 years after the treatment, as is the case with most cancer treatments. So the follow-up of these patients has to be coordinated by the different caregivers, not only to follow the disease, but to follow the patients. The surveillance program should have two types of impacts. One, upon the detection of recurrence and early detection, and an impact also upon the outcomes, survival outcomes of these patients, and also an impact upon life quality. This is the situation that we have with cervical cancer today. Year after year, we have some possibilities of new treatments for patients with cervical cancer that have recurred. When we have central recurrences, we have the possibility of surgical treatments, generally with big surgeries, but the disease can be controlled above 50% in well-trained centers. And also when there are distant recurrences or multiple recurrences, there are new management possibilities thanks to the biological therapies, basically. And what we have seen appear is inhibitors of EGF, for instance, the GOG 240 trial, and also trials are being carried out with immunotherapy, especially anti-PD-L1 therapy. So having new tools for the treatment of recurrence is very important, and thus it is very important to have good follow-up programs. Cervical cancer relapses, like in the case of many tumors, might be symptomatic or asymptomatic. And one of the questions that we ask ourselves is whether there is a difference between these two groups in terms of overall survival. It is important to have an early detection of the disease. If the disease, even in asymptomatic patients, the detection can improve oncologic outcomes. And we've seen in the literature huge heterogeneity in the different surveillance programs. So what is the impact of quality of life if we do a necessary test? And what is the impact upon the cost of the different health systems? This is to show you that despite we have no literature and no clinical trials justifying this, this is to show you how each one of the activities that we have regarding the detection of relapses in survivorship programs, there are some activities do not have a very important impact. Cytology in patients that have been treated look that only the cytology affects 7% of the relapses. The images also have imaging is important, but more in distant recurrence. But when we have central relapses or pelvic relapses, even some mixed relapses, the most important activity is to do a clinical exam and talk with the patient. Ask the patient. So cytology only detects between 0 and 17% of relapses. And probably the best yield that we have for detection of relapses is provided by physical exam and the visit of the patient and the exploration of the symptoms that these patients might present. This is to show how the curves, the survival curves behave when patients have only central relapses or distant relapses, and how the survival behaves in a different way when the patient presents or does not present symptoms. These are the recommendations of the NCCN guidelines. In Colombia, we're very interested in taking into account this kind of literature that provide guidelines that specify things better. And the NCCN guidelines of this year emphasize that all the follow-ups of these patients have to be done mainly with the clinical history and physical exam, and use additional imaging studies or surgical exploration studies only when the patient presents symptoms or some alterations are found during physical exam. This is what the Europeans do, and the European Society of Oncologic Surgery takes into account not only the clinical detection, but also other aspects of follow-up that personally calls my attention. And I think it would be important to take that into account in a project like this. First, who should do the follow-up? The specialists, general practitioners, or nurses? When should it be done on an intensive basis or in a minimalistic way? What should we do? Only clinical history, tumoral markers, images, and evaluate other issues, such as detection of secondary primary tumors, quality of life, and costs. This is more or less what one should take into account when you do the follow-up of an oncological patient, when you are going to establish a program. And definitely there are no randomized trials well designed telling us which is the best means of doing follow-up of patients treated for cervical cancer. Our proposal is to compare an intensive program based on symptoms in patients with a diagnosis of locally advanced cervical cancer that have received treatment. And the research question is, what is the 5-year-old survival of patients with locally advanced cervical cancer that have received the intensive care versus symptomatic care? This is the primary objective. The secondary objectives to do a social demographic analysis of the population, analyze disease-free survival, to describe the proportion of asymptomatic patients with relapse, to describe the proportion of symptomatic patients at the moment of relapse, describe the recurrence rate in both groups at follow-up, describe the death rate in both groups at follow-up, and evaluate levels of anxiety, depression, and patients' satisfaction included in the 2 arms of the program at 12, 24, 36, 48, and 60 months. These are the eligibility criteria. The inclusion criteria, just to mention that the exclusion criteria are patients with history of other neoplastic diseases in the last 5 years before the diagnosis of cervical cancer and the presence of synchronous tumors, and take into account that we have to think about all the inclusion criteria. We need an informed consent, and we need a follow-up of 36 months. This is a description of the 2 arms and the activities. We have the routine surveillance with physical exam, evaluation of symptoms, CT, abdominal pelvic CT at 6 months, after treatment at 12, 24, 36, 48, and 60 months, chest X-ray annually and cytology annually. In the symptomatic surveillance group, only a physical exam, evaluation of symptoms, and additionally CT of abdomen every 6 months and cytology annually, not to have ethical problems. And if we find recurrent disease, the diagnostic has to be confirmed basically through biopsies, and the treatment has to be provided to the patient according to the patient's characteristics. We estimate a sample size of 1,300 patients, roughly taking into account a 10% loss to follow-up, and this implies about 657 patients per arm. We would like to do the study with a wide participation of North American centers and, of course, Latin American centers. We believe we will have about 2 years of accrual. Potential barriers for our project. I'm about to conclude, is the sample size. Participation of other international centers is required, especially for SWOG approval, but we believe that with 5 recruitment centers, we can have adequate recruitment. The Cancer Institute of Colombia can contribute with about 600 cases, 360 cases potentially a year. The costs are covered by the health system, but this should be evaluated in other countries. By way of conclusion, we do not have randomized trials validating the best surveillance program for cervical cancer patients after treatment. There is little evidence about the use of some tests, and it is important to establish not only the impact on overall survival, but also on quality of life of these patients. Thank you very much for your attention.
Muchas gracias, doctora Costa, por su presentación.
Thank you, Dr. Costa, for your presentation about surveillance. Now, we go to the round table. We advise you to write down your questions on the icon question and answer. We will have 28 minutes for discussion. All of the participants can now show your video. Erika would like to start with the first question. Thank you, Deisha. Thank you, Dr. Acosta. We will start the round table. And Dr. Eguiguren, Dr. Javier Retamales, and what mechanisms do you integrate primary healthcare data with hospitals in the network? And is there any initiative to replicate the experiences obtained in the northern part of the metropolitan region, to replicate that in other parts of the metropolitan area or in the country?
Thank you, Javier, for the question. The integration of information is a problem and continues to be a problem. There are still lots of difficulties to establish a dialogue between the different information systems, the primary care and hospital. In some spheres, information is shared, but regarding the follow-up of the patients, that is where we have more difficulties. There are structural difficulties to integrate the network. And also in the diagnosis, we detected, for instance, regarding HES and not HES, which is a health guarantee system in Chile. There are differences in the way that is applied. So these are things that we still need to work on, and this would help integrate the network in a better way. In the pandemic, we've seen how there's a lack of information systems allowing to establish this articulation. Now, regarding whether we can replicate this experience, I think that we do not have a very concrete experience, but I have the feeling that the intervention and the project has been widely disseminated, and I think that participation is something that is growing. I have the feeling that during the pandemic that has been interesting. We've been following traceability actions for COVID, and we've realized how the critical context of the pandemic has generated a possibility, and the teams have had to articulate and have found creative ways and participatory ways to do this. We identify aspects of the process that we experienced also during the equity. We see elements that happen today given the urgent need to have an articulation. Here we have an issue with the visibility of primary care, the role of primary care in the articulation of the system, and that is something towards which we should move.
Thank you. We have a question for Dr. Tammy. It calls the attention that the study has mostly participants of a high level. The lack of those groups, it is because of lack of services, or was it intentional in the design of the study?
I don't understand clearly what you mean by high levels, educational high level. Graduate, postgraduate studies, because it's an oncologic centers. We are speaking about the two national cancer centers where most of the nurses have some kind of second level studies. Maybe if this was at the level of primary care, the individuals would have undergraduate studies only. I don't know if I'm answering correctly to the question.
Bien, yo tengo otra pregunta.
I have another question for Dr. Egiguren from Dr. Miller. Considering the lack of oncologists, it's been discussed the possibility of involving primary health care to follow up of patients that have concluded their cancer treatment. Do you think this could be tackled by the methodology of equity project? What do you think, Dr. Egiguren?
Thank you very much, Bettina. Greetings to you as well. Thank you for your question. Yes, I believe that the articulation of the network improves the effectiveness of responses at all levels. Because as you say, and we've seen this, the chronic patients are sort of trapped in specialized care, and maybe their requirements do not need for them to stay there. This happens for different reasons, and one of the reasons is the trust that exists or doesn't exist between teams. It is vulnerated because of the fragmentation. So to try to find agreements between teams and try to find solutions for patients to confidently move from one area to the other. The Equity Cancer Project, which will begin next year, aims towards that, or is focused on early detection, but is related with the construction of strength in primary care, to strengthen primary care so that primary care will be able to follow cancer patients. And I'm sure that that will favor a more timely change of patients from secondary care to primary care by recognizing the role of primary care.
The next question for Dr. Acosta. And the question is whether the two types of surveillance fall under the guidelines of NCCN. That question is from Benas Parks.
Thank you for the question. No, the guidelines of the NCCN, and if you go to the literature from the United States, they go more towards a symptomatic follow-up than an imaging follow-up. So it wouldn't be the same.
I have another question for Dr. Tammy from Dr. Frank Villarroel. The collaborative study that you mentioned regarding people who live with HIV aims at patients with cancer associated to HIV or other solid cancers that are not directly related to the infection? Are there local statistics in the South Cone of lung cancer in cases of HIV with or without antiretroviral therapy? I think the first question first, Dr. Tammy.
Yes, I will clarify a little bit something. I participated in a trial in 2011, which was the largest randomized trial for smoking cessation in HIV patients. The study I was mentioning at the end for the evaluation of risk factors for cancer is in sexual and gender minorities independently from the diagnosis of HIV infection. So at any rate, I am very much open and interested, and I can provide literature to any of the collaborators in the region, because today I continue to work with smoking cessation in this population. It doesn't necessarily have to be in patients that live with HIV that concomitantly have a cancer diagnosis, but we include them in our smoking cessation anyway. Right now, we are starting to begin a project with transgender males and females with HIV infection or with cancer diagnosis. So any collaboration with the region is welcomed. This is an area that I'm deeply interested in, and I would love to learn from any of you. It's an enormous opportunity for me. Thank you.
The next question, Dr. Acosta, from Javier Tamales, Chile. Considering that the new FIGO 2018 considers MRI for the assessment of cancer, cervical cancer, what increases the sensitivity of parametrial invasion from 50% to 90%. How do you integrate this test in your protocol? Because for many centers, is the new gold standard.
Thank you, Dr. Retamal. A very important question, but I would like to clarify that regarding cervical cancer, FIGO, well, cervical cancer is one of the cancers that are considered related with an infection, same thing as gastric cancer. And these are tumors that appear very frequently in countries with low human development index mean. So FIGO has maintained, until the last classification, has maintained the classification of cervical cancer stage using only clinical methods. In this last classification, 2018, FIGO introduces the possibility, but it's not mandatory, to do imaging in some patients when you do not have imaging possibilities, and to do some surgical procedures to do the evaluation of nodal involvement in patients with locally advanced cervical cancer. Nevertheless, the clarification is made that only if these tools are available, you can use them, but that if you cannot use them in a country because of economic restrictions, then you continue with the clinical classification. MRI has been used more for staging of patients before treatment, and it is very important, especially in initial tumors, to define surgical states or conditions that need other type of treatment. But for follow-up purposes, it is not important. So what we want is to compare the clinical follow-up with a follow-up with some other activities that have been traditionally used in our environment, like cytology, like chest X-ray, like that. But MRI, we have not included in this proposal.
Along the same line, Dr. Acosta, we have a question from Dr. Gamboa, whether the clinical arm shouldn't only be images in case of symptoms, but not the CT scan every 6 months?
That is a possibility. Yes, sir. Thank you very much. It is a possibility. And I hope we will be able to discuss the project at greater length. So that the project is approved. In the symptomatic arm, we included CT and cytology, not to create a problem, an ethical problem that could be a question asked to us from any ethics committee, that the symptomatic follow-up could have some unbalance regarding the intensive follow-up. This is why we included it in that way.
Bueno, la
Aisha,
pregunta es para la doctora Tami otra vez, del doctor
the
Bettina.
next question for Dr. Tami, Bettina Mueller. In a previous session of the symposium, we learned that maintaining a change in the lifestyle requires to act at different levels, family, work, public spaces, etc. How do you integrate those aspects to your project?
Yes, that is a very good question. And here in the United States, and I was writing that on the chat, in the MD Anderson Cancer Center particularly, we do a lot outside of the cancer center. For instance, the smoking cessation program of the MD Anderson is not only for the patient with cancer, but also for the patient's relatives, because we understand that if there is no support in this process, then it is difficult for the patient to maintain abstinence. Also, we go to the communities, and part of the research carried out in prevention and control of cancer is outside of the institution. And this is something that we have tried to integrate in many of the projects that we have. So yes, if we could do this also in Latin America, the pilot project in these cancer centers, we work basically with the patient, but we give tools to the professional to help involve the social and family aspects while the patient is quitting smoking. But many more things can be done beyond that. There's a study we're going to publish soon. Last week, we received the approval from the journal, has to do with an evaluation we did with oncologists in Mexico and Colombia regarding the prevalence in health professionals that also smoke in our countries. And those that do not smoke are exposed to passive smoking, because in some centers there are places where you smoke. It's not accepted, but there are corners in the parking lot, or what we learned in one of the focal groups, several drive a car, take a drive on a car and smoke, and then come back to the cancer center. So there's a lot that you can do to move forward in quitting smoking. I'm always scared to say that what comes to Latin America is a tsunami, because in Canada and the United States, there are more and more restrictions in terms of forbidding in public spaces to smoke. What is the cigarette industry doing? They are looking towards Latin America, because we have laws, many laws, but sometimes we do not implement them properly. So they are not complied with. And we see the electronic cigarettes coming in, and there's a flourishing market for tobacco companies in Latin America. So if we do not move forward and quickly, then what will come is many cancers and chronic conditions associated to smoking with a much higher prevalence.
Hemos visto nosotros en otros centros europeos que los pacientes oncológicos, los pacientes al momento de ingresar al centro.
Oncologic patients, when going to the center, they already go into a program for smoking cessation that involves family members, people who live with the patients. Maybe that could be a good way in our oncological hospitals to have a program that can provide support and above all education at all level to healthcare staff and the patient and his relatives.
Yeah. Well, there comes my comment. The fact of being from Venezuela gives me a local perspective because I speak about the MD Anderson and I speak about the cessation and prevention center you have at home. But financially, this is impossible to maintain in our centers in Latin America. Why? Because even more so, it is impossible to maintain it in any cancer center in the United States because the financing that the smoking center has at the MD Anderson comes from a suit against the tobacco company years ago. And it's an extraordinary amount of money that the MD Anderson receives because of that, and that is only devoted to this purpose. We do not have special revenues for smoking cessation. This is why I devote my research to mobile tools, something that can be sustainable for the region, because we won't be able to have the wage paid by the center for a professional that would be there 24 hours a day, because we wouldn't need only one professional, but many professionals for the population of a cancer center that smokes. So we need to be more creative in the way that we propose research in our region. These have to be sustainable and possible to implement. And I saw that when I lived in Venezuela over 15 years ago. We say yes to everything because we are enthusiastic to collaborate, but we have to sit down from every side, from all the countries that are part of collaborations, and to check whether it is sustainable and whether it can be implemented given the social cultural context and reality of that specific country.
Yes, technology must help us improve education. And I would like to ask another question to Dr. Egiguren about virtual consulting and research, observational studies. We know that the gold standard are randomized studies. Observational studies can answer useful questions, simple questions. Could this be another tool to hold or conduct studies at that level?
I believe very much in research. If we go to the academic world, knowledge based on reality and connected with health services is basic, and obtaining information to make it available to the teams for their decision making, I think that's the way to go. We can have great experiences or great evidences, but that do not have an impact upon the systems afterwards. I think that a research that is closer to the territories has that capacity, because as academicians, we facilitate processes, but actually those that provide their knowledge and make the decisions should be the teams. What the research that we did shows is that the construction based on the teams generated sustained solutions, solutions that remained in time. We would like that the evidence we produce be translated into improvements. This type of processes convinces me in methodological terms for transformation purposes.
Thank you.
Thank you.
This is for Dr. Egiguren. Do you know about qualitative studies being used in oncological research using participative method? And how could we include more of those studies in clinical research?
I think that we do less than what we could and should do. What we're going to begin now The study will deal with early cancer detection and the response from the system. And we hope to generate qualitative knowledge regarding the experience of the patients. In this project that I mentioned, one of the tools was to establish which were the experiences of the patients and to take all their history, all their experience, their continuity, the care they have received. We realized that there were many interruptions, and those interruptions had explanations that were related with the way in which the health services are organized. So I believe that in cancer, beyond any doubt, the experience that we've had with Dr. Isabella Barca and the team that's been working with virtual consulting or these online advisories, that allows them to discover where there is, for example, excessive waiting. This has to do with organizational aspects of the network. And this could be transformed by us. So I think that the qualitative aspect has a lot to contribute, and mixed studies are even more powerful because you've got the data, you have the magnitude, but then you have the deeper explanations that quantitative methods cannot provide.
Dr. Acosta, we know that patients with cervical cancer, once they complete their treatment, one of the things that is pending is how to improve adherence to follow-up, because once the treatment is completed, patients disappear. How can we generate some ideas to improve adherence in case of follow-up?
No se lo escucha.
Ya,
Ahora
ya.
sí.
Tenía cerrado el micrófono, pido excusas. Gracias por la pregunta. Es
I
una pregunta.
apologize for the microphone. It's a very interesting question, and it is a situation that we see very frequently. Not only the lack of adherence, but lack of interest from the patient, but also, not only that, but also the barriers that exist for an adequate follow-up. So a part of the study tries to evaluate quality of life, tries to see the impact upon the patient of using different follow-up systems. There are other things that might be very interesting, and maybe we can think of other studies, and I invite Dr. Tami to this, because we can use technologies. I have read quite a bit, and I've seen in some other countries where you can do follow-ups, especially when these follow-ups are symptomatic, through apps. And the patient comes to the oncologic center only when the patient has a symptom, or according to a checklist, the patient is invited to come, or the person doing the follow-up through the app tells the patient when she should come to the medical center. We have barriers in our countries, but also in the United States, such as distance, transportation, and through apps. Probably, if you can demonstrate that the follow-up should be symptomatic, then probably it's even better if we do an intensive follow-up with exams. You could use that kind of apps. I would be delighted, doctor. Thank you very much for keeping mobile apps in your radar. I wanted to share that our research group for a year has been working on mobile technology, not only apps, but one of the grants from the NIH is consulting through text messaging for smoking cessation. We have the grant that I mentioned, the randomized controlled trial for smoking cessation in individuals with HIV. That was an intervention based on telephone calls. So there are many areas, and I agree with you, not only smoking cessation, but I make available, I offer everything that I have learned in terms of mobile technology, development of mobile applications, creating decision algorithms that are so useful in the clinical sphere. So I couldn't agree more. Technology can be very important in our region, particularly because the number of smartphones in Latin America is very high. I checked for the financing application I submitted to the NIH. I had to study that, and it is incredible the number of smartphones that exist. Some people believe, no, in Latin American country you won't find them, but no, today it's very easy to have mobile phones, and if they are not iOS or Apple, they are very affordable. So it's very possible to have a smartphone. So it would be my pleasure to collaborate with other centers. So there we have a commitment for the near future. I accept that commitment. Where should I sign the contract, please?
Thank you. And an announcement for all of the attendees on how to collaborate with the doctors. We're going to close the discussion now. I would like to tell you that we're going to show a poll before going to the break. Thank you very much to the panel members for sharing your studies, and I hope to see you in the next session. Thanks to everyone. Thank you. A pleasure to have shared with all of you. Good afternoon.